Welcome to everybody. Thanks for joining us. My name is Dr. Mary McGowan, and we're here to hear a webinar called Understanding Lipoprotein(a). What does the American Heart Association scientific statement tell us? And we're very lucky to have Dr. Gissette Reyes-Soffer, who's going to be speaking to us, but we'll introduce her shortly. So, as we usually start our webinars, it's important to have a medical advice disclaimer. The information in this webinar is for your information. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute medical or other professional advice. If you have questions, please follow up with your doctor and medical team for specific recommendations pertaining to your treatment. And I'd like to encourage everybody to say hello in the chat. When we looked at the people who had signed up for this, we have patients and physicians and researchers from all over the globe: Mexico, India, Egypt, Switzerland, Norway, Canada, Australia, Argentina, Spain, Colombia, Taiwan, Lebanon, and Malaysia, as well as, of course, the bulk of us are from the United States. So use your chat to introduce yourself. Tell us where you're from. Make sure you change your chat settings to all panelists and attendees so we can all see who's chatting with us. And if you have a question, please select the Q&A to ask our speaker a question. Answers will be given during the live discussion at the end of Dr. Reyes-Soffer's lecture. And I'd like to thank our sponsors. This is an Lp(a) Community in Action program. The Family Heart Foundation gratefully acknowledges the generous support of corporate sponsors to the Lp(a) Community in Action program and our family heart partners. So Amgen, Novartis, Konica, Silence Therapeutics, thank you very much. And now I'd like to take the opportunity to introduce Dr. Gissette Reyes-Soffer. She is a clinical translational researcher and the Herbert Irving Assistant Professor of Medicine at Columbia University Medical Center. Dr. Reyes-Soffer and her team have NIH funding to study the metabolic pathways regulating Lp(a) levels. Dr. Reyes-Soffer was a member of the National Heart, Lung, Blood Institute Working Group on Lipoprotein(a), and the recommendations of this group were published in the Journal of the American College of Cardiology. She has authored numerous reviews on lipoprotein(a), health disparities, and inflammation. Her team's work has been published in Circulation, Journal of Lipid Research, and Science and Translational Medicine. Dr. Reyes-Soffer is the current associate editor of the Journal of Atherosclerosis and Frontiers in Medicine. She's a board member of the Journal of Lipid Research and a member and fellow of the American Heart Association. She's a member of the European Atherosclerosis Society and the Society for Biochemistry and Molecular Biology. So it's a pleasure for me to have Dr. Reyes-Soffer to present to us tonight. Her presentation, as I mentioned, is titled Understanding Lipoprotein(a). What does the AHA scientific statement tell us? I think this will be enlightening, and I'm really looking forward to the program. Thanks so much, Gissette. It's great to see you.
Thanks for having me, Mary. This is a great opportunity for us to have a very nice conversation about lipoprotein(a). And I'm just going to share my screen. Great. So thank you so much to the Family Heart Foundation for inviting me to speak to you today. I'm an assistant professor of medicine at Columbia University, and my research interest is in lipoprotein metabolism, not only LPA, but many lipoproteins. But today I'll be focusing on the scientific statement that was recently published in the ATBB journal. Hold on one second. Here we go. So the first thing I want to say is that I am a representative of many people that were in this pond together. And I consider myself fortunate to work amongst these talented scientists. I had a co-chair who was from Canada, Marlis Kaczynski, who's an expert in lipoprotein(a) and has been doing this for many more years than I have. And so we had on the left a combination of expertise. And some people will describe the statement as dense. And the reason why the statement is dense is because we try to encompass not only the clinical implications of what lipoprotein(a) is doing, but also how can we bring in the basic science and merge it into one cohesive understanding of this atherogenic risk factor that's not only atherogenic, but also causes calcific aortic stenosis and many other things. And then on the right, you'll see that we, my colleagues and I, who are a little younger in the field, Pia Kamstra, Chan Henfred, and Calvin Yang, also assisted this group to make sure that this was up to date and with the standards that we think going forward should be sort of followed for lipoprotein(a). The first thing I want to discuss with this audience is what is lipoprotein(a). So when you go to the clinic, you hear ApoB100 measurement, ApoA, LPA, is it the size, is it the mass, is it cholesterol, is it triglyceride? So a really, really easy way to explain to patients and also to understand it as a physician who's just out in private practice is to know that lipoproteins come from the liver. And they travel in our circulation. Most come from the liver, the ones I have here on the slide. And they travel in our circulation and we need them because they're protected, right? So all the fat has to be carried in these lipoproteins. And they're all listed, the ones that we have here on the left. And I'm gonna just add my pointer. I apologize for not having it up. So these are lipoproteins and they all vary the reason why we call them different names is based on how they float in your plasma, so how dense they are. And so when somebody says to you, I have high lipoprotein(a), everybody's questioning, well, what does that mean, right? And so it is just a different particle that's circulating, carrying cholesterol and triglyceride, and it has many other things. When they speak about the mass and the size of it, they're talking about the whole component of it. And so really, really important to know that LDL cholesterol and your low density lipoprotein is a different particle. So when people describe lipoprotein(a) as an LDL-like particle, it's kind of a comparison, but let's say for goodness sake that all of them contain this protein called ApoB, and that's why they say it's LDL-like. But it's not only LDL that contains this ApoB. Chylomicrons have a shorter version of the ApoB, B48. Very low density lipoproteins have ApoB, and you see they're a little larger. These lipoproteins have ApoB. The reason you don't know too much about these is because we don't really measure them in clinical practice, but they're there and they're in your circulation. And so you are very familiar with LDL because that's what your doctor tells you it's high or low. And you're familiar sometimes when you're at risk with ApoB100 because your doctor will measure ApoB100. And that's going to become important later on when we talk about it. What makes LPA a little different is that it has this ApoA, another protein bound to it. And that's your LPA. It's just an ApoB with this little a, and then many other components that are also in other lipoproteins. So I hope that was clear and that at least we can start with knowing what it is. Okay. Now it gets really tricky because you only have one LDL. But most individuals have two LPAs. And so you can have this B with a medium size A, or you can have this B with a small size A. And that makes it really hard for us to try to develop assays to measure it in your blood and for us to understand which is the lipoprotein that we should be paying attention to. And you have two, but some people have 70% of one and 30% of others, or 50% of one, 50% of another. It, you know, and the sizes vary too. You can have two small ones, two medium ones, and that's what makes it a little bit trickier to try to get a pinpoint our hands on. I have this slide up, and the reason why I like to present this slide is because I wanted you to see the liver, and I wanted you to see that these proteins are being produced from the liver. And I wanted you to understand that they're also degraded in the plasma. That's it. Not very complicated, very easy for this audience. Now, on the right, I wanted you to see what I do for a living, and we're not going to spend a lot of time on that because clinically relevant it is not. But I put it up because I want you to understand that this is our liver, and you have this B that I told you about and this A. And this is where it all happens. They bind, We don't know why you have ApoA. We don't know why the body decided you needed another protein to be secreted, but we actually don't understand too much about why we produce it, how it gets cleared. We have a lot of research and we have a lot of studies that have pointed it in some directions, but we're not yet there. And that's what my lab spends most of its time doing. So why do we care so much about it? I like to say that we have all this research, and you'll see that through my slides. You can take a picture, I have everything that I'm gonna say today is based on literature that's been published and scientifically sound. So nothing that I will say hasn't been confirmed. So on the left, you have the physiology and the pathophysiology. So as you know, cardiovascular disease, it is a sign or a symptom, correct? You have chest pain or your cholesterol's high, those are all signs. What happens before to get us to that level, we don't know too much about, right? We're not very good about preventing us getting there, but we're very good at knowing when something's wrong. So LPA, having high LPA levels from genetic studies and also from just measuring in blood, even though we don't know how to measure it very well, has been found to be linked to aortic stenosis, atherosclerosis, so plaque, right? And also to heart attacks, so ischemia. The reason why it's so varied is shown here on the right. So this is a really complex particle. So when you take it out of your blood and you look at how many things are inside of it or it's linked to, these are all the things that are inside of it. These are all different proteins and enzymes that are bound to this protein. So we've identified various areas where we want to really understand what's going on. So it's linked to coagulation, it's linked to lipid, right? Cholesterol, all these proteins that regulate lipid in our blood. And then it's linked to this inflammatory response. So it's a particle that's not only linked to this athero, and your doctor tells you, you eat this high fat, your vessels are gonna accumulate plaque and the plaque is gonna go away and you need to decrease it. No, that's not it. This is part of the story. But for LPA, we have other parts of the story that we really don't understand too much about. And I'll show you an old slide from 2009 to show you that it has been found that when your plasma levels of LPA increase, so does your risk to have a heart attack, a myocardial infarction, or an ischemic stroke. This was published in JAMA in 2009. And then I'll show you more recent data. So just now, recently I didn't write the date, but this was 2021. And so there was a study that analyzed 460,000 adults in the UK and biobank. And what you can see here is that there's some racial differences in the levels of lipoprotein(a), but more importantly, you can see here that when your LPA levels are greater than 150, and this is the red line on top, there's an increase in the risk, in the cumulative incidence of ASCVD. I love this paper, so I put another slide in just to show you that high LPA concentrations were identified in 53 individuals, and that was was in about 12%. So that's a high amount of individuals that were recognized as having an LPA level greater than 150 nanomoles per liter. And then out of those, an incident ASCVD event occurred in 6%. So a lot of people say, well, how about if you have high LDL and high LPA? Is it the same risk? Or how about if your LPA is high, but your LDL that everybody's concerned about is not low? So we have a study here that was published in the Journal of American Heart Association, just letting us know, and I'll go through these lines because I think it's important. So the bottom line is your low LPA with low LDL. This is sort of brownish color. This blue line is your high LPA with low LDL. So you can see that there is an increased risk, right? And if you have low LPA and high LDL, it's a little bit higher. But then if you have both, you can see this red line. It's just, the risk just goes up incrementally. I want to say that there are other conditions that you also should think about. So it's been linked to many things, and we don't have a strong evidence for these, but it's been linked to aortic stenosis, peripheral artery disease, estrogen depletion, FH for sure, hypothyroidism, renal insufficiency, and inflammatory states. So LPA goes up in all these, and you should have these on the back of your book. I think in 2018, the fact that someone, a celebrity, had high LPA and was working out and was eating a healthy diet and did not have high cholesterol or any previous risk factors really uptick the amount of information that came out for LPA. And I think that I want to highlight the LPA Foundation and also the FH Foundation, because a lot of the work that has taken place since 2018 to now has been driven by the increase in media and the increase in knowledge that we have. And so I just want to highlight that it's one of the factors that you can't tell people lose weight or, eat a healthy diet, because LPA does not change. So I spoke a little bit about the measurements before and why we have some issues with measuring. And I mentioned that this ApoA varies in size a lot. So there's some difficulties. So we don't have a current standardization of the methods that we have. So every hospital measures it with a different assay, and it's not necessarily validated. The ApoA size makes it really difficult for us to have an assay that can capture it with the correct antibodies. And so what do you do, right? So I would say use an assay that's independent of the number of ApoAs that you have, and that exists, but there's not many of them. Use an assay that reports in nanomoles the number of particles, not the mass. And this was my first slide during the talk. You want to know how much LPA you have, not how much cholesterol, phospholipid, everything that's within your LDL. And that's what this assay does. The assay must be calibrated and referenced, and the assay should be validated and have acceptable precision limits. And so the goal of all this is to ensure that we have common cut points so that we can compare populations, and also to assess risk, because we can't compare the risk of having high LPA if we have all different assays all over the place. So you'll say, well, should I measure it? And I say, if you do not have this assay, measure with whatever available assay you have. And why is that? The reason for that is because if you have high LPA, it's going to be high anyway. Where you are going to get into trouble is that middle LPA level, which we think is around 30 or 50 nanomoles, that if it's a little higher or lower, so we don't have cutoffs. So if you need to measure it with the assay you have for now. LPA is undermeasured. These are data from 2019 from 2 institutions related to our hospital. And obviously, I don't have how many patients came in for primary care or for secondary prevention, but you can see here that it probably was not 798 patients or 813 patients at the other institution. So it is undermeasured, and we need to pay attention to it, and we need to come up with ways to really educate. Race is a variable, and there's been many studies. The Interheart study, the ARIC study, and the MESA study have all published that African Americans and Hispanics have higher levels than whites. And so we need to pay attention to that. And we are not sure whether they are at higher risk. There is some data indicating that they may be at higher risk, but the data is in very small cohorts. This is the data with the actual numbers. I showed you this slide before, and I just wanted to say these are in nanomoles per liter. You can see here that the mean in whites was 19 nanomoles, while the mean in blacks was 75. Chinese and South Asians were also a little elevated. And then there's this really small signal that women may have. We're not sure whether these were postmenopausal women or not. They may have a higher level of LPA versus men. And I wanted to show you again the adjusted hazard ratio. So as your LPA level starts increasing, you can see that around 50 nanomoles per liter, you start seeing this large increase in the adjusted hazard ratios for risk. So I mentioned that we're not sure what happens between blacks and whites. And you can see here in this ARIC database, they had LPAs not measured in nanomoles, but in milligrams. I don't like to convert, so I won't convert here. But they didn't see many differences in the event rates. screening for lipoprotein(a). So I mentioned before how important it was to have the support of the Familial Heart Association and also of the previous LPA foundation, which was Sandra Tremolis. And I have to say, these billing codes that were approved in October 2018 could have not been possible without the advocacy of patients that have high LPA. And we now have 2 codes where we can actually put it in the medical record: asymptomatic patients with elevated LPA, E7841, and the family history of elevated lipoprotein(a), Z8343. And I know this is not important for people all over the world, but at least in the US, this really helps us to be able to code for these and get insurance companies on board to start measuring this. And so I'll measure a little bit about the statements that we have. So I've been part of 2 the statement that we'll discuss today and later, but I also was part of this NHLBI working group recommendations led by Sam Samikas, where we really in 2018 gave an overview of where we think, where we thought the field should move. And we've moved the needle. We certainly have. We have much better data from the UK Biobank and from other studies telling us that it is a risk enhancer factor, and we have been able to provide some mechanisms that are regulating it. The National Lipid Association also had a clinical statement in the Journal of Clinical Lipidology, where they really stressed that the time has come for us to start measuring LPA and paying attention to it. And then I'll speak a little bit more about the guidelines and how we are doing here in the US. We have LPA as a risk enhancer, but I think other countries have gone a little bit above and beyond that and really advanced our understanding of this lipoprotein. And then I like to say that, we have stakeholders in this conversation now. So I like to think that because NHLBI, which is an NIH institute, is on board, I think there will be a lot more research and funds to provide so that we can get through this. So there's 2 guidelines that recommend measuring LPA once in a lifetime, the Canadians and the ESC. And then we have it here as a risk enhancer. And I would like to, so this is who should get it: less than 60 years old, family history of early disease, first generation relatives with higher than 200 nanomoles per liter, FH or other rare lipid mutations, calcific aortic disease patients, and in those with increased 10-year risk for ASCVD. And the last statement is really important because this calculator for risk works in elderly subjects, right? All these risks were estimated based on age. And so pay really close attention, because your patients that are having events with high LPA may not be at a higher risk. And so you have to really be paying close attention. And I didn't want to do this talk without including the Endocrine Society clinical practices. They actually have some really nice statements on lipoprotein(a). They state here that maybe you don't need a repeated measure if you already have an LPA in childhood and early adulthood. And I think Mary and I maybe will have a conversation about that a little later on. Just to bring it back to the clinic. So a little consult. So this was an email that was sent to me, and Dr. X writes, I had a 56-year-old man who had a small artery stroke and had incipient risk factors, LDL just moderately elevated, and MRA normal. The MRA is the magnetic resonance angiography. LPA levels were 260. He wasn't on potent statins, but at one point may consider niacin or apheresis if it remains elevated. Do you see patients, or is there someone in cardiology, endocrinology sensitive to the LPA issue? So 2 things. When we're going to write LPA, write LP and little a, because we have another ApoA that is not related to this lipoprotein. So I always like to mention that to individuals. Very important if you're going to get a consult to say lipoprotein little a. So my response was, is this 260 nanomoles or 260 milligrams? I'm glad you caught this. Totally agree that it should be measured. And then we provide context. So you need, should this individual see someone? And the short answer is yes. It's a cardiovascular risk factor. You need to optimize treatments because we don't have a targeted treatment, but we have options. And you need counseling because it's a genetic risk factor. And so we haven't spoken about that before, but it is when you have high LDL because of diet and lifestyle in your 50s or 60s, you have a heart attack, you couldn't detect that before. But with LPA, it's genetically determined, and we don't think it changes that much during a lifetime. So we have a really unique opportunity to measure it and prevent people from having disease at a later age. The treatments to lower lipoprotein, I mentioned lifestyle modification doesn't do much. It does lower ApoB100, which is an atherogenic lipoprotein. So you do want to decrease levels to the max. There is some temporal variability. So although I told you that LPA is mostly genetically determined, in the ongoing treatment studies for antisense and sRNAs that are being in development, they're in phase 2 and phase 3, they've noticed that some of the participants have had some changes in LPA levels, but there hasn't been more than 15%. So you should lower your overall cardiovascular risk. And then the only FDA approved treatment to lower LPA right now is apheresis. And on the right, I love this slide that was published in the Journal of Cardiology 2017. And it just shows that example, if a subject had an LPA of 150 milligrams per deciliter, what the effects of statins are. Statins do not lower LPA. They either raise it by 10 to 20%. What the effect of niacin, a PCSK9 antibody, CETP inhibitor, or an ApoB antisense, 20 to 30% reduction. Apheresis lowers it 30 to 35. The latest data I've seen is more like 60. I've seen some data 60% if it's done every 2 weeks. And the novel treatments that are in development, and these are not at the clinic level yet, are 70 to 90%. Again, these lower ApoA. So one component of lipoprotein little a, not the whole particle. The one important thing, since we don't have a targeted treatment, is to remember to assess cardiovascular risk. It has been proven by many papers, and I am quoting them here because I think that in the field we've made a big mistake with not doing this, that ApoB, which is that protein I spoke to you about, is a better marker of cardiovascular risk than LDL cholesterol. And so we should really not forget, this is not a new concept. This is a great ApoB calculator from Alan Snyderman. You can do it online, and it'll tell you, if you put in the ApoB of the patient, it'll tell you where, what risk category the patient falls in. And he actually, Peter Attia, had a really nice podcast that I enjoyed listening to because it was very informal and back and forth, and it allowed for questions that would not be asked in another format. It's a little long, but I think you can get through it if you really want to know more. These are the indications for apheresis. They were changed in 2020. That's why I'm putting them here. So apheresis for FH had been, we had 3 groups before, but now this group D has been added, that the LPA greater than 60 with an LDL greater than 100 milligrams per deciliter also qualifies you as one of the groups that can obtain apheresis. Again, the reference for that is on the bottom here. I like this slide a lot because it just tells you that LPA is important, that it's a risk factor, that whether is in combination with high LDL or by itself, it increases risk. So now let's see what we can tell you. So the background I just gave you is pretty much everything we wrote in this scientific statement. We wanted to give the clinician, but also the patient and the scientist, a cohesive document where you can look and see what the data is from beginning to end. And I think we've achieved that. So what can you take to the clinic, right? So I think the take-home points are that you can measure it. If it's high, you can provide guidance to a patient and family members, that you should measure ApoB 100, and that you should lower all other risk and ApoB 100 in a patient that has high lipoprotein little a. And then we gave you really, really nice tools. We gave you 2 tables. So we gave you this table so that you can use this calculator. If you have the 10-year risk calculator, and that's something that you use in your clinic a lot, you can use this calculator. But I told you that there's limits to how you can use that. If you have a young patient, what are you gonna do, right? But then now let's talk about this ApoB that really confuses people. So how much ApoB is within your LPA? So if you're measuring ApoB there's a conversion factor that you can use. So if your ApoB is 100, this is 2,000 nanomoles of ApoB. And I told you that we should measure LPA in nanomoles. So you can actually know how much ApoB is being carried on that LPA. So if it's atherogenesis, right? If it's this athero question that you have, and we all know ApoB very well, right? You know how much. So if somebody has 20 nanomoles, the LPA ApoB is 1%, right? If the LPA concentration is 200 nanomoles, then LPA is 10% of your total ApoB. And these are easy numbers, but I actually was talking to Mary about this. We can develop a quick calculator. So you don't even have to do this in your clinic. You can just have an app and do this very quickly. And I think somebody will have that within the next month or two. These are some of the resources that I like to use. I think the FH Foundation, the Family Heart Foundation now is doing an amazing job taking what's known and what's not known and bringing all the stakeholders to talk to each other. And they've really done an incredible job. I like the ApoB app, so please use it because I think we need to start measuring more. And then I wanted to mention my funding disclosures. My lab is funded by the NIH. I also have some internal awards from Columbia University where I work, and I am involved in some outcome trials for not just LPA, but also for other lipid-lowering therapies. I think that's it. So I think I stayed within my time that I said. You're on mute, Mary.
Yeah, you were perfect.
Okay.
And so there have been some questions coming in, and the first one is what you just sort of ended with, to talk about the clinical trials for drugs lowering lipoprotein(a). So we know that Amgen has a small interfering RNA, olpasiran, and Novartis is working on pelacarsen, which is an antisense oligonucleotide. And the question is, we know that from some of the phase 2 trials, we have some data on how much they lower Lp(a). I don't know if you want to talk about that. And we are doing the phase, the cardiovascular outcome trial for Novartis right now. But if you want to talk a little bit about what you can expect in terms of Lp(a) reduction.
So the general thought is that it's between 60 to 80%. Correct. There are some individuals, just like the PCSK9 inhibitors, that get this amazing reduction. What that looks like long-term, we don't know. These programs are young. Right. The other thing I would tell you is that it's an ApoA treatment. So it's lowering this little protein that's bound to your ApoB. So we really don't know. All the studies show that ApoB is also going down. So that's great, because that means that whatever ApoB you have bound to it is also not being produced by the liver, and it's lowering ApoB also. But the amount of ApoB that's going down is not the same as the A. So they're very promising. They will not be, the cardiovascular outcome studies are expected, I think, in 4 years if we're lucky, right? And then if the data looks amazing, which there's no reason why it shouldn't at this point, there hasn't been much of a signal with adverse events, then we can have them in the clinic very soon. So I think it's going to be a life changer for sure, for many individuals that are stuck in this, what do I do?
Right. Right. So we have another question. In families with a history of premature cardiac disease and or familial hypercholesterolemia, the American Academy of Pediatrics, the National Heart, Lung, Blood Institute recommends a lipid panel at the age of 2. Would you be measuring a lipoprotein(a) in a child whose family has a strong history of cardiovascular disease at that age?
So it's a great question. My short answer from what I have read and what I know is yes. Why not, right? There's no reason not to. I had originally thought, well, what happens when you tell this to a child or to a family? What are they going to do? Is it going to create anxiety? And I recently presented, and a pediatric lipidologist said to me, we're not in that era anymore. We're in the era of open communication between patients and physicians. And if a child is out in the playground or playing, football, and he has chest pain and he knows he has LPA, that would that was the example that was used, that would be amazing, because then he knows, no, this is something I need to pay attention to. But if a child has chest pain, he says, my heart is hurting a little bit, I probably hit it. So I think I believe in screening for high lipoprotein little a, of course, within the context of a very monitored environment where it doesn't create anxiety, and where we're not really explaining to people what could happen, because we don't really know, right, who's going to develop the heart attack or not. So that's also an issue.
Absolutely true. And what I like to tell people in my clinic is that, there are a lot of medications being studied right now, and maybe we don't have something to treat you right now, but by the time you need something, by the time, 5 to 10 years, we will likely have medications for lipoprotein little a. And another question is how challenging are animal studies? Because animal models, as you point out in your scientific statement, are hard to come by for LP little a. The only only animals that have high LP little a or have LP little a are monkeys, old world monkeys, hedgehogs, and apes. So how do we do that? It's not mice and rats we're studying.
Baboons too, they have it.
Okay.
So the mouse studies have been tough. My colleague Marley Kaczynski, who was the co-chair on the statement with me, for years she's been working on this. She has one repeat that she's been putting into mice, but she better than anyone knows the struggles with trying to understand this, because there is no mouse model. So human studies, the relevance to clinical practice is that the studies that we do have to be done either in monkeys or they have to be done in humans. And so that makes it really difficult for us to get at the mechanisms that are regulating this, but we're getting there. And so most of my other colleague, Calvin Yang, at UCSD, who's also part of this scientific statement, has tried a couple of models, and also, it's the best of the best trying, and it doesn't work. When you try to knock this out or knock it in, it's not the same.
And another sort of clinical question. This is from David Leach, who says, high-dose niacin is high-dose niacin still recommended as a non-prescription way to lower LP little a? I've heard varying reports, but my lipidologist recommends it.
So, I showed you the data in that table from Samika's 2017 paper, 30 to 40% reduction. Gerald Watts in Australia had done some studies on niacin and mechanisms, lowering of lipoprotein little a. And I think it does work. I think in the US, we don't use it as much. The flushing is an issue. But if the physician is comfortable and has the buy-in from his patient to understand how niacin works, and again, I go back to this shared decision-making. If there is a treatment that works for that patient, then I don't see a reason not to use it.
Yeah, I know that I've talked to Sam Samikas, and sometimes Sam uses it.
Yeah.
But I know the AIM High trial where niacin was used, and even in the people that had high LP little a, niacin didn't offer further benefit beyond the statin. So it's complex.
Yeah, and it's that cardiovascular reduction, right? So right now we have these studies, and what's holding us back from saying that this treatment works is that not only do we need it to lower LPA, but we also need it to decrease risk. Because if your risk is not from just decreasing this protein, then why are we treating you, right? So that is the question, right? So yeah, if I would say that monitoring ApoB is a good gauge of atherogenesis. Whether that works the same for LPA, we just don't know. That's what I would say. And I will highlight that slide that I showed you about the proteins. I know it's a nerdy slide because it has a lot of research in it, but it shows you that LPA is doing other things. It's doing inflammation, it's doing coagulation. So there may be other pathways that that we can look into in the future and get a better sense of what is actually, when you lower it, what is it that we need to decrease the events, and that, the aortic stenosis and sort of that.
And I think that's getting to, Thea has a question. What can we do until the new meds come on the market? I'm on Repatha, I'm on Nexletol, but as we know, Repatha is likely what's lowering the LP little a little bit, and her LP little a has gone from 300 to 260 nanomoles per liter, kind of what we would expect. I don't know if you have some thoughts in terms of, just in terms of a good lifestyle, taking those medications, getting the LDL to as low as humanly possible.
So that is the goal. For right now, all we have is to decrease your other cardiovascular risk factors, which are ApoB. So, so if you get your ApoB as low as you can go, you need ApoB to produce LPA, right? So it's the carrier of it. So when you think about it, if you're at 260, that means that you have a lot of ApoB in that LPA particle, right? If you're already lowering the other ApoB that much. And so that's a really interesting case. Again, I think, Mary, you hit it on the nail. Do everything else you can at this point because we don't have anything.
So another, my cardiologist doesn't think that measuring LP little a is important in treatment. How do I bring this to him? I'm 48 and have FH, diagnosed at age 21. I'm on statin treatment since then and recently added Praluent. My LDL is well managed at less than 70. Your scientific statement says it all. Did you suggest bringing the scientific statement to her doctor?
I just had a journal club with the Northwell team, the Northwell and Cornell team here. And, a lot of the stroke attendings and a lot of the cardiologists said, we don't really measure it. Now they're starting to measure it. And so it's $36, I think, the cost of an LPA assay right now. It's not that expensive. I think that physicians may be a little hesitant because they don't have the tools to counsel you on it and they don't know too much about it. So there may be some issues of communication. I don't think that someone that doesn't measure is a bad cardiologist or someone who doesn't know what they're doing. I just think they're doing what they can. And so the tools you have are to lower ApoB. So if that's being done appropriately, I don't necessarily think, if you want to know, I think that that's something that you should tell him that I would like to know because it has been proven, scientifically proven, that it does increase your risk. And if there's treatments coming, I want to be on the pipeline. I want to be there. And so that's sort of a stimulant for him, I think. A nice stimulant, right?
Yes. Another person is taking a statin and knows that they have high LP little a and concerned that statins raise lipoprotein little a. So why am I taking a statin then? And so I think that that's a good question, a good thing to answer. What do you think?
I think we the data on statins is not out, and I would hate to say that such a great treatment to lower LDL cholesterol and ApoB should be discontinued in anyone who's at increased cardiovascular risk. I think that you really need to understand what kind of LPA you have high and how much this statin is actually raising your risk rather than reducing your risk based on this ApoB reduction that you're getting. So that would be my thought on that. I don't know if you have something else, Mary, that you...
Yeah, no, I think that, even though we should be looking at ApoB, and I'm going to ask you a question about that, the cholesterol treatment trialists have found for every 40 milligrams per deciliter you lower LDL, you lower cardiovascular risk by about 20%. So somebody may well be getting a substantial reduction in their cardiovascular risk on a statin, even if the LP little a goes up a little. Another related question from Lori, and I am thinking that this question is maybe a case of having a lab test that was milligrams per deciliter to nanomoles per liter. I've been put on a statin following an MI. LP little a was found to be 104 at the time of the MI. After the statin was introduced, it skyrocketed to over 225. I think that may be the case. Even though it brought the LDL down, it increased my LP little a. I think you really need to look at the units that your tests were measured in. I can tell you, Lori, I had a patient in tears in my office. Our clinic recently switched over. We send our LP little A's out to the Mayo. We switched, and the Mayo switched from milligrams per deciliter to nanomoles per liter. And a person had exactly this same thing. And she burst into tears. And I said, did you look at the units? And she was so relieved. So I would see if that might be the case.
I agree. Nanomoles and milligrams. So that was the case that I put up from the
Right.
From the neurologist. They send you these data. You alarm the patient. You alarm everyone. So units matter, and also repeating it. So there's nothing wrong with repeating it with a validated assay. If you really have, if you do this test and you think that your site is not measuring it correctly, and you find that another site can measure it more with better validation of the assay, then you may want to do that also.
So another question that comes up is, I've heard that LP little a levels can rise after menopause. So do you recommend a repeat LP little a test once somebody's gone through menopause?
The latest that I've heard, and again, the latest that I've heard is that yes, that you should measure LPA. Since it's a genetically determined factor, you shouldn't expect it to raise to a level. If you have low LPA levels, I don't necessarily think that menopause is going to create you to have high levels, because they're mostly genetically determined. But there's about 20% that could be other factors that we don't understand that well. But that's where the low versus high is great, right? Because if you're high, then you're at a risk and you want to measure it again, maybe. But if you're low, you are 20 nanomoles, 10 nanomoles, you don't even have it, I'm not sure you should go around measuring it.
Right, repeat. So Jeff asks, sorry if I missed it, but what would be considered a good ApoB?
Oh, so as low as you can go. We've heard with the PCSK9 studies, 20, 30, 10, I don't know. The lower, the better. It's the same as an LDL cholesterol. The lower you can go, the better.
Right. And it looks like Jeff is having his measured. I don't know where you live, Jeff, but you're having yours measured in grams per liter. Generally, ApoB here is milligrams per deciliter. So we'd have to do the math, but yours is probably 70 milligrams per deciliter. So that's
yeah, that's below 60.
And so you did mention this, but I just think it's important to bring it up. Your AHA scientific statement points out that recent studies, and this, most of the time people don't get serial lipoprotein little a measurements, but in the phase 2 clinical trials for the pelacarsen or elpisiran, they're looking periodically at lipoprotein little a and finding that even though we say it's a very stable level, it does have some variability. And in some cases, you're suggesting measuring it twice and taking the average. Would you suggest that for everybody, or just?
I don't think that's a bad practice to have. Even with our LDL levels, if somebody has it high, sometimes if you took it when they're not fasting, you take it again, when they are fasting. And so I think for the cost of this assay and for knowing if it's high or low, I think it's worth a second measurement and I don't know if an average is the right sort of, I wouldn't expect it to change more than 5%. And a CV less than 4% is usually, a variation CV for an assay usually is less than 4%, what we in the field are comfortable with.
One of our FH advocates, Gail, is asking if LP little a can increase after major surgery.
I don't remember that literature off the top of my head, but it increases after inflammation. So
Right.
Any inflamed state, and I'm not sure, post-surgical would consider you sort of, it could go up, but I don't, I haven't seen the data on that. I'm sorry, I can't answer that.
Yeah, so I think that there is data on it being sort of an acute phase reactant, and following an MI, we can see it go up, and following like even a strep throat. So as you said, inflammation. So I would imagine that following major surgery, we're cautioned not to measure lipoprotein little a. If somebody, and same with lipid panels. LDL can plummet in the face of an MI, a heart attack, but LP little a can go up. So I usually wait if it hasn't been measured as the person's rolling in the door with an MI. I usually wait. One of the things that has come up
Right, so I'll
is
tell you something about this.
sure, please do.
Just because of the inflammation talk that we're having, and I think because we're in the middle of the COVID sort of uptick again.
Oh yes,
Um,
important.
so during COVID, everybody with high LPA was like, well, are we at increased risk? Because we're already at this, like, we have this protein that's involved in coagulation and inflammation and atherogenesis. So do people with COVID and high LPA do worse? And so the reason why I mentioned this is because the only way that we could do that, we can't measure LPA in post-COVID individuals because it may go up because of the inflammation that they were in and because of all the other things that were going on in the treatment in the sort of an acute setting. But we can do is we can look at the genes and the SNPs within those genes and estimate how much, how high the LPA of those people were and look at outcomes. So we're doing that study now.
Oh, that's great.
So we'll have an idea of whether genetically inferred levels of LPA put you at more risk of COVID, of having a worse COVID outcome.
Mm-hmm.
So that, to your point of, we can't really measure it in an acute inflammatory state. But surgery is like, you're getting fluids, you're getting you're getting nutrients. It's not,
Mm-hmm.
I don't necessarily describe surgery, and I'm not a surgeon, as a post-inflammatory state, but I may be wrong.
Well, I just, if once you've had surgery, you may have a major scar, you may, be healing it, and or you could get infected. You hope that people don't. Another important question that's come through, and this really has a lot of resonance for some of our FH advocates, FH and LP little a advocates. We do have an FH advocate who has lost a sister very untimely, and she had an LP little a of 83 milligrams per deciliter, so milligrams per deciliter, and passed away at the age of 23. And autopsy shown to have a heart attack. And she has this advocate. She and her mother and her grandmother have all now become advocates, and the initial advocate is a pediatrician, so she is lecturing far and wide on LP little a now. But it's very clear that some people with elevated LP little a don't develop symptomatic vascular disease, and your scientific statement brings that out and lists as one of the priorities to develop tools to identify people with elevated LP little a who don't have an increased risk, and those with sort of modestly elevated LP little a that have a very increased risk. And so do you have any thoughts regarding these potential mechanisms, and why some people with seemingly very elevated LP little a have a normal lifespan, and others with a modestly elevated level have such a terrible outcome?
So I've seen, there's really no sort of solid research to tell us which LPA particle is going to create disease. We just don't know. It's believed that the inflammation part of it has to do with it. And, I don't like to get into the oxidized phospholipid story, because as you and I have had many conversations, and I've had these conversations with others, we just don't know if that is the culprit. It could definitely be one of the culprits. Sam Samikas and Joe Witztham have really pioneered that. And there's a way to measure it, actually, clinically, measure how much oxidized phospholipid your LPA has. But I think that we're not there yet. I don't know if we really understand, the cases that we've seen vary age, vary race. And so we're not sure yet. We think by lowering it, we're going to prevent disease in most individuals, but we're just not sure whether what is it about this particle? It has cholesterol, it has phospholipids, it has all the other apoproteins that I showed you, ApoE, ApoH. It may be that we discovered novel pathways that we didn't even know. So I think a lot is to be studied for us to really pinpoint identification. I always say this, grabbing novel biomarkers that can tell us if this is actually going to be an LPA particle that as physicians we should pay attention to. I mean, families are, I see that, at 20, that's very young, so we just don't know.
No, absolutely. So one last question that's come up: should everybody have an ApoB measured?
Yes, if you're going to have LPA, because I'm going to tell you, so the reason why I say yes is because I'm telling you that people with a family history of disease, so I'll change my answer. People with early disease in their family with a predisposition to have cardiovascular disease should have an LPA measurement. And on that second note is that knowing your ApoB once you have your LPA would give you some idea of how much of your LPA is actually carrying, how much ApoB is within that particle. And so I think they go hand in hand. Not that everybody now, when they get their first lipid panel in life, should go out and measure an ApoB. I'm not saying that.
No, but it was a big takeaway for me from the, I think the formula was just so important. And I honestly, I hadn't known that you can multiply ApoB by 20 and get nanomoles per liter, that it's an easy conversion. So that is great.
No, I think that's the take home, that now you use ApoB, and ApoB has been shown, and there have been other propositions to measure LPA cholesterol. There's manuscripts out there. I didn't mention it today because I just don't think that we're there for that assay. I think the cholesterol content of LPA varies a lot, and so does of LDL. So I don't know if we can use it as a biomarker, but we have ApoB, and ApoB is validate. The good thing about ApoB is that all the issues I mentioned with that we can't measure LPA accurately, ApoB is standardized. All hospitals, all countries, cholesterol is not standardized, triglycerides are not standardized, but ApoB is. And I learned that from listening to Alan Snyderman over and over again.
He drives it home.
He does. And so now I'm going to drive it home like him. Maybe now we'll listen.
No, that's great. Gissette, this has been wonderful. We are so grateful for you for helping us understand lipoprotein(a) a little bit better. And I'd like to encourage everybody here. I know that some of this was sort of high level, but I'd love to encourage everybody to visit our new website for more resources. As you know now, we've changed our name to the Family Heart Foundation, and in large part, it's because we have a bigger mission beyond familial hypercholesterolemia, and it's really reaching into lipoprotein(a) as well. So we encourage you to visit the website for lots of resources. And, I'd like you to consider the Family Heart Foundation in your year-end giving. Giving ends family heart disease. And so if this has been a good resource for you, we would encourage you to donate today. And I'd like to thank everybody for coming, listening to the webinar, and feel free to contact us. We are here for you, and we are really grateful that you joined us today. Thanks so much. And Gissette, thank you. It was really wonderful. And thanks for writing that scientific statement. It's really enlightening.
Thank my colleagues.
And your colleagues as well. Some of whom are in our registry. Bart Duell, for example. Yeah.
Yes, it's a big pond. It's a big pond, and we all work together. So
it is true. Yes. It's great. Well, thanks so much.
Thanks for the invitation. This was great.
Thank you.